My name is Roche. I'm a senior fellow at Bruegel, and I contributed to organizing this conference, and I will chair the second session. I just would like to welcome all of you and introduce our first speaker, Martin Székely, if I learned how to pronounce your name correctly, who is the Deputy Director General at DG Sante of the European Commission since 2014, but he has been the Deputy Director General since 2011. And I think I don't have to emphasize the importance of health issues on which this event will concentrate. Luckily, the Commission, along with the OECD and the European Observatory on Health Systems and Policies, now regularly prepare reports about health in the EU. Mr. Székely will introduce how these reports are organized and some of the key findings of the recent publications. But certainly we want to go beyond that, and we also invited many people from many different institutions to comment and give their perspective. So without any further ado, let me invite Mr. Székely to give an initial presentation, and then we will have two panel discussions. Thank you.
Thank you. I understand the presentation is loaded, so I just need to, okay. So, good morning. First of all, I must apologize, my voice is not at its very best, so I hope it will last for the entire presentation, so apologies for that. Thank you for the opportunity to explain also our work in this area and why it is so important. And let me start by saying that I think we all recognize that we are at a very crucial moment when it comes to health in Europe. Of course, there's still a lot of positive in our health approach to health. We still have some of the strongest health systems anywhere in the world. If we look at some of the key indicators, I can just mention one, of course, something everyone mentions, life expectancy. We have one of the highest in the world. But I think it's very important also to really dig beneath the headline figures and really try to have a much deeper understanding of what's going on, because we know there are significant shifts and changes happening, some for better, some for worse. Just to give an example on the life expectancy, although it's very high, as I said, we see that the increase in life expectancy is slowing down, and in some cases even reversing, at least in some countries. And this leads to a growing concern over whether we can, in the future, sustain the quality of public health and healthcare that we have become accustomed to and that our citizens rightly expect. We also face a number of challenges, big challenges, climate change, an aging population, but also constant and new health threats, antimicrobial resistance, very underestimated, the disruptive effect that this will cause. Even the digital revolution, of course, very exciting, lots of potential, but if we're not careful, a digital divide could end up accentuating the health divide. And it would be the ultimate paradox if digital technology, which is supposed to make location less important, ends up making it more important. So that is a risk. We also have growing polarization, growing differences, growing gaps that also present our policies with a lot of challenges. So it's clear, I think one thing everybody agrees on is that business as usual is not an option. And we cannot afford inaction in health. We have to take decisions, hopefully the good decisions. And this brings me to the issue of evidence. You cannot take good policy decisions without the best possible and available evidence. And this we see as one of our main responsibilities in the European Commission. Of course, the delivery of healthcare is the responsibility of the member states and the regions, and that is for a very good reason. But that needs to be supported. We have a role in the European Commission to support our member states, to help them take the best decisions that, of course, are in line with their resources and their circumstances. So this is where this state of health comes in, because the state of health was always designed to be primarily aimed at decision makers. there's a lot of evidence out there, very good quality, lots of work and studies and publications. But speaking also as a former national civil servant, I know how important it is to have the evidence presented to you in a very concise and clear way that really underlines the decisions that you will need to take or recommend. And that is something which is not always easy to do when you're faced with hundreds of pages of academic, high quality, but very, let's say, complex analysis that needs to be boiled down to the essential messages. And this is why we're very grateful for the cooperation from our colleagues in the OECD and the European Observatory, who will be here today as well. And their collaboration is extremely useful. So we see the state of health as an infrastructure at the service of policymakers and policy influencers. And indeed, this was one of the main areas of work in the past 5 years. It's a legacy we intend to continue to build upon. So I will start by, I think it's, first of all, to briefly introduce the cycle and outline the main conclusions from our companion report before we go a bit deeper into the analytical work on the state of health and also the opportunities provided by digital tools, which I understand will be the subject of 2 panel discussions this morning. So what is the state of health in the EU? The state of objective of the state of health in the EU, is to support member states by strengthening the evidence we have, first of all, on health systems in Europe. Our aim is to build an infrastructure, as I said, to present health system information, expertise, and very importantly, best practice. It's not enough to just point out the situation, but also to point out how these situations could be addressed. The European Union is, or should be, a community of practice. We are all facing the same issues, even if we all have different means, but that there's a lot that can be done for member states to learn from each other, and this is one of the main aims. I'll say something about that later. So as I said, our partners in this endeavor, and I understand we'll have colleagues here, Dr. Josep Figueras from the European Observatory on Health Systems and Policies, and also Dr. Guillaume Dida from the OECD, Health Systems Analyst. And indeed, I can say from the outset that this initiative would not have been at all possible without their help. I mean, the expertise they have brought into this work has been absolutely indispensable. So I would ask you very much to see this as a very much a joint endeavor between our 3 institutions. And we have, I think, very complementary strengths. And the role of the Commission, the OECD, and the Observatory, I believe, are very complementary. And also, another thing to point out is that we wanted to find the right balance in this exercise between having, of course, something which would be applied to all member states, but would also respect the specificity of member states. You cannot just propose one-size-fits-all approaches in health. It will not work. Our member states are very different in many respects, but they all face very similar challenges, and they all have access to the same toolkit in terms of financial programs, in terms of other policy measures. And so it's very important also to find the right balance between addressing all the member states together, but also recognizing that they need also some country-specific advice and analysis. So, you may have seen this before, but I'll go through it again very briefly. This is a biannual exercise, so each cycle takes 2 years. First of all, it starts with the Health at a Glance Europe in year 1, which this is a horizontal assessment of health systems performance. But then every other year, so in year 2, we produce a number of country health profiles. So these are individual profiles. You may have seen some of them outside, and you're very welcome to have a look at those, of course. in addition, so these are country specific, so per country, it's a very similar format, but they're very tailor-made to the situation in each specific country. And also, in parallel with that, we have what we call a companion report, which is the Commission's input into the process, which identifies some of the biggest trends. Of course, we do not aim to be exhaustive in each cycle. This is not about producing the encyclopedia of health. But every 2 years, we identify a number of topics linked, of course, to the Commission's policy agenda and try to put the spotlight on those because we see that there are maybe opportunities or issues that need to be brought to the attention in a special way. We also have the possibility, but this is, of course, completely voluntary, to have what we call voluntary exchanges with the member states. And a number of member states have taken up this opportunity, so we can, in the member state itself, so these happen in the member state, actually dig deeper into a particular issue, which the member state itself will choose. And again, here the assistance and the role played by the OECD and the observatory is absolutely invaluable. And in fact, we've had a good number of these exchanges already. So, of course, the starting point for our work is the Commission's policy objectives in the area of health systems, which is basically that we aim to ensure that we can achieve effective, accessible, and resilient health systems in the EU. We base all our work on health systems on these three principles. And this is, in fact, one of the main lessons learned also from the aftermath of the financial crisis, that our health systems were often under severe pressure and often failed in these three dimensions. So we base all our analysis on these three aspects, which we believe characterize or should characterize a good health system, a robust health system. It should be effective, deliver what it's supposed to deliver, of course. And it's not just delivering treatment. Health systems should deliver much more than just treatment, of course. They should be accessible. It is a distinguishing feature of European health policy that we do not just aim to offer the best possible healthcare, but the best possible healthcare for all. This is, I think, a distinguishing feature of our approach in Europe. And one thing we learned particularly from the crisis was that our health systems need to be resilient. They need to be able to adapt to shocks, which can be predictable or unpredictable. And we had a number of significant failings in the past, especially on this dimension, that our health systems were too rigid to be able to adapt to changes. So let's move on quickly to some of the key findings. I just highlight the Commission's companion report, which draws a number of conclusions. But let's go straight to some of the big trends. And I think it's the next slide. So the 5 big trends, I mean, there are, of course, many, but these are 5 we wanted to highlight in particular. 5 big trends that are happening and that are indeed transforming our health systems. The first challenge we take note of is the issue of vaccine hesitancy. Some of you might be surprised why we highlight this so much. It is indeed one of the biggest threats health systems face. If you look at the increase in life expectancy over the past 50, 75 years, much of it can be ascribed to 2 things: sanitation and vaccination. That accounts for the bulk of the massive increase in life expectancy that we have managed to achieve, not just in Europe, but globally. And this is often underestimated. You know, people underestimate the contribution that vaccination makes and just how much of a important pillar it is. It is at risk. We face, in some countries, not in all, but in some countries, plummeting vaccination rates. It's very often been ignored, even among health professionals. themselves, not sufficiently promoting what they know, is perhaps one of the most effective public health tools, where, of course, vaccines are available and exist. We also need to ensure that we continue to improve health literacy. It's shocking, for all the sophistication in our societies, the degree of health illiteracy there is. And this is something which, of course, will create problems not just in this area. There is even, of course, disinformation, some of it may be resulting from naivety, but some of it also deliberate. And of course, that is finding fertile ground because there is a lot of lack of knowledge about this topic. In a way, of course, vaccination has become a victim of its own success. The problem is when vaccination works, it works so well, the diseases it prevents disappear. And so you don't see the risk anymore. Of course, things are very different in other parts of the world. Infectious diseases, I mean, sometimes there is the mistaken belief that now it's all about non-communicable diseases. Infectious diseases, some people think are a thing of the past. Well, just turn on the news this morning and see what the biggest news item is. It's the new coronavirus in Wuhan, which is already, dominating the headlines. Infectious have never gone away, and they will never go away. So we have to continue to ensure that this old enemy, which can take various forms, we are protecting ourselves against. And vaccination, where available, is one of the most important tools we have. Our evidence, the evidence we have collected, suggests there is a lot of scope to improve health literacy and also to counter disinformation. And one of the key facts which emerged is that the best way to do this is through the health workforce. Health professionals remain, in all countries, the most trusted source of information about health. And therefore, I think one of the biggest failures we have had is sometimes disengagement of health professionals themselves. If I could just take one indicator, we know that there are significant numbers of health professionals who are themselves not vaccinated. Now, this is very worrying and sends a very dangerous message, even if it's not always an intended message. So this is something, obviously, we would want to prioritize, and we are recommending member states to prioritize. Second conclusion, digital transformation, another big thing which is happening. This is, and the key word here is transformation. A lot of people think the key word is digital. The key word here is transformation, because digitalization of health is not about doing digitally what you would normally do in a more traditional way. I mean, if you talk to health professionals, for example, one of the most common complaints from doctors and nurses is that they say they are being reduced to data entry operators, which is true in many respects. When we go to our doctor in the clinic, they're busy entering a lot of details about us, and that takes away precious time from the communication with the patient. But that's not the aim of digital. Digital is about transforming. It's about, for example, moving away from the hospital-based model to a patient-centered model, having better follow-up, being able to monitor patients independently of location and give them the best possible advice in real time, if possible. It's about supporting professionals in their work, how you can make use of artificial intelligence and big data approaches to really provide support for professionals. This is a radical transformation, or should be a radical transformation. And also when it comes to in the issue of health promotion and disease prevention, there is sometimes the mistaken belief that digital is just about hospitals, about treatment. If you look at prevention and primary care and also how the integration of care, all this can be greatly transformed and facilitated by digital technologies. Now, as I said, however, we should not forget the key element here is transformation. This is not about just spending money on the latest technology or the latest gadgets. Without a complete different approach, a lot of this will be very wasteful expenditure. We know from past examples like imaging, that if you do not have very good criteria for deciding who needs to be scanned and who doesn't, you will have a lot of over expenditure and waste of money. And the same could happen on an even larger scale in digital technologies. Another element to point out is that a lot of the innovation in digital technologies is happening outside the traditional healthcare arena. A lot of the big players introducing these technologies are themselves not healthcare companies in the traditional sense. So you have the big tech giants, IT giants, they come from other angles. And often they are not European companies. So also a big challenge for Europe will be how to ensure that European values and European principles that underpin our health systems are not thrown overboard because we are just importing technology without thinking how the technology is going to fit into our systems. And that is something obviously which is of concern. Now, I don't want to be negative about this at all. In fact, I'm very optimistic about these technologies. I mean, they have certainly potential to change things we have been talking about for a long time. The patient-centered approach, which we have all been referring to for years and years. This has always proven to be difficult because ultimately, a lot of the treatment options we have today are in hospitals. But if you consider digital solutions like apps, wearable technologies, also the possibility to interact with the patient, for the patient to be able to contribute his or her own observations, for example, digital technology greatly facilitates or could greatly facilitate this. It's not possible to do this in the traditional approach. So it's really, we have a golden opportunity finally to realize what we've been saying, that we need to raise awareness and empower citizens. There are, of course, a lot of barriers. I'll just mention a few: interoperability, privacy concerns, reimbursement criteria. It's not straightforward. You have a lot of different approaches in countries. Europe is a very fragmented place, and this does not make it, of course, easy or attractive for this technology to take root. In particular, for example, we need to have a good governance framework for the secondary use of data. We should also ensure, and this is another conclusion, we should really emphasize digital health literacy. Third conclusion, I'll try to go faster because I understand the time is, but there's quite a lot to say here. So first thing is we still have gaps in healthcare accessibility. So the report mentions some examples, the situation of irregular residents, problems in rural areas. We are now hearing the term medical deserts increasingly. This is an issue, of course, which will lead, if not tackled, to major gaps also in the quality of and in the outcomes and the quality of healthcare available, and would have a lot of other social consequences as well. A fourth conclusion was about skill mix innovations, including the issue of task shifting. The role of the professions is changing. Often we have problems of staff shortages, but we should not see task shifting as just a quick fix for staff shortages. Skill shifting should take into account the changing nature of the professions, the training that professionals are given. For example, I mentioned vaccination earlier. In some countries, there have been very good results by, for example, empowering and allowing nurses and pharmacists to vaccinate. If through that you can improve the outreach, that is something to be considered. There is no reason why not, if the right training is in place, as it often is. So we have a number of examples, positive examples of task shifting among health workers across the EU, and this is something obviously which we will continue to monitor, and there are many best practices in this area. However, any change in roles often creates challenges to traditional hierarchies, and that it does lead to tension. And therefore, any such shift needs to be accompanied by adequate education, training, active involvement of the organizations involved. And I repeat, it should not be seen or presented or driven by, for example, things like cost-cutting imperatives. I mean, this should be a means to improve systems and not just to cope with emergencies. The final and fifth finding is an issue, of course, which will be very high on the Commission's agenda as well over the next few years. The issue of how we can ensure that in the face of promising but often very expensive innovative technology, European patients can continue to have access to affordable, innovative and sustainable medicines. And all these three terms are very important. There's no point in having breakthrough treatments if only a few people can afford them, or if those treatments end up crippling health systems and cause a lot of other negative impacts. This is a big challenge. Europe is not a unified place in this respect. We have growing concerns from countries, small member states, poorer member states, that do not have access to some of the medicines. Sometimes patients have to wait up to a decade to get access to life-saving treatments. So, what's next? So these are the key findings. I mean, of course, it's not exhaustive, but these are the key findings in the report. We aim to follow this up with voluntary exchanges with the health ministries, of course, purely voluntary, but some have already expressed interest. But most important from our side, we will make sure to feed all this evidence into various EU policy processes. As I mentioned, the issue of access to medicines, but also digital technologies, these are all very high on the Commission's agenda. And also we have already started work on the third cycle, which will cover the period 2020-2022, where we'll of course continue to follow some of these issues and also maybe dig deeper into some aspects. So if you would like to obtain any further information, we have more detailed information on our website. You can also write to us. And this is, again, something which is an ongoing process. So you could also see from the previous report as well, evolution in certain aspects. And we hope also to maybe to get certainly your ideas and feedback on how we can improve this product. And as we're already working on the third cycle, maybe make some further improvements in it. Thank you very much. Thanks.
Thank you very much, Mr. Seeker, for this very nice and comprehensive and informative overview of the state of health cycle in the EU and the 5 key areas that the recent companion report has emphasized. I would just like to introduce briefly Caroline Costons, who very kindly agreed to chair the next session. Caroline is the director of EuroHealthNet, which is the European Partnership for Improving Health, Equity and Well-being. And she has been working on health-related issues for many, many years now on EU health policies, health inequalities, regional development, sustainable development, health promotion, and many, many others. So let me pass the floor to you immediately. Thank you very much for accepting to chair this session.
Thanks a lot, Solt. Thank you. And can I please ask all of the panelists to come to the floor here and take a seat? Thanks for the nice introduction. For those of you who do not know EuroHealthNet, we are indeed a partnership of mainly national public health institutes and regional health authorities. And we were actually very happy to support the Commission and the OECD and Observatory in helping to disseminate the evidence in various countries. So only last week we were in Italy, in Bari, where we helped the ministry and the Puglian region to present on the findings and on the inequalities in Italy and on the high out-of-pocket payments. And they really took it up, and it's important to see that how member states can work with this evidence. And we will be further supporting events in Sweden and in Finland and in Greece. And I heard there are other events to further disseminate and work with the outcomes. So the purpose of this session is to further get an idea of the state of health in the EU. And I'm delighted to have all the panelists here. And we would like to further look a bit more in detail in the country profiles, because there has been a lot of work by the OECD and Observatory to look at the situation in every country, and did also a cross-country analysis. So I would like to give the floor already to two colleagues. The first is Guillaume Dida. He's a policy analyst and health economist of the OECD. And together with Josep Figueras, director of the European Observatory on Health Systems and Policies. And I would like to ask you to further elaborate on the presentation of Martin by giving the facts and figures. Guillaume, would you want to start? Yes. And there is also a PowerPoint presentation that I assume is somewhere.
Would it be possible also to get the point?
I hope.
If there is.
Yeah, I know for your presentation you need some of the nice figures, but maybe you can already start.
We can just give it a start very quickly. The idea, first of all, good morning everyone, and thanks very much for this invitation. It's really a great pleasure for us to share back a bit of our experience and define the main findings of this very interesting policy process and collaboration across the three organizations. The idea of that's just to give you with the main findings of the country profiles, just a brief overview. But of course, what we advise you is to check also each of them, including the companion report, because they all include quite a thorough analysis of the situation in the countries, comparisons, and also some general thoughts about the directions taken and the approaches of the situation. So basically, all the country profiles are structured and organized around the same format. Basically, we start always by informing a bit on the situation of the health of the population. So we use the main usual indicators, be it mainly the life expectancy at birth, but also across income groups, across social groups, across gender. But also we check on things like the self-perceived and self-assessed health, the healthy aging, or the perception of health through age and so on. Then the second chapter, which is the third in the order, but it's the second one that we use, is to report back a bit on risk factors of the population. What are the main issues? And so we also have the major ways of displaying it and indicators. The fourth chapter is an analysis of the health system in the country and a description of its functioning and the main reforms that have been presented and adopted in recent years. And the fifth chapter is divided in three subsections, which address three pillars of the performance of a health system. First, it's the description of the general effectiveness. The second one is the accessibility, so be it in terms of physical accessibility, but also financial accessibility and all the other aspects. And the final one is the resilience of the health system. So it's just saying like how is the health system and the health system able to cope with sudden changes and modifications and so on. So that's the structure of the country profiles, and all this country, all the country profiles are built around the same scheme, meaning that you can easily find in any of the profiles and information that you would need or be interested in finding across countries. So I think I will go without presentation, basically. So that's fine. So just basically, the first element I wanted to describe, and then I will hand over to Josep, who will also tell you a bit more on how health system managed to handle the challenges, is just to describe the first two elements, which were the health of the population, our main findings on this, and the risk factors. So I will start with the health of the population. Basically, and as already mentioned by Mr. Seychelles, we enjoy, and we have the chance to enjoy in Europe, very high levels of life expectancy. what we report is the latest features data from 2017, which says that basically the average life expectancy in Europe is 81 years. It's 90.9, 80.9, so 81, let's say. So it's very high. The thing is that we have also to go a bit beyond these broad numbers, because basically the situation is much more, I would say, we have to qualify a bit this statement. The first thing is that the good news is that it has increased over years. I mean, since 2000, we gained roughly 4 years of life expectancy, which is really a lot, and which was already, we started from a quite high level, so we managed to keep an interesting growth on that front. This has to be also qualified because, as stated already, in recent years, things have started to stall. And in some countries, and we still have to see if this is just, something like a movement that will recover later on, or if it's something more sustainable. And this only time will tell us. And we have started to investigate also in the countries where we have seen this decrease in the growth, even full decrease of the life expectancy. What were the reasons? And maybe we can discuss that later during the discussion. The other thing is to check beyond these broad numbers, what are the nuances, the differences across groups. So we know that there are important gaps across gender, important gaps across income groups, and across social ethnic group. We have also in Europe some marginalized communities facing very much lower rates of life expectancy than the average. So this has to be also checked, and across countries, obviously, the life expectancy is much higher in Western Europe than it is in the states that most recently joined the European Union. So we have to go a bit beyond these numbers. If you just check, for instance, the difference between in life expectancy across educational group, you have roughly 7 years among male, 4 years among women, and these rates are also very, very different if you check Eastern European countries and Western European countries, with usually twice the gap you see in Western Europe. So that's the first point. Life expectancy has grown up. Life expectancy is high, but there are important nuances across groups. Also, the second point, if we go now on risk factors, what we know is that roughly 30% of death in Europe can be attributed to behavioral risk factors, which is extremely high. Oh, great, we have the presentation back. So I move on. So now we catch up directly here, and it's a good thing in terms of time. So what we know is that, yeah, as I was mentioning, 40% of deaths in Europe can be attributed to behavioral risk factors. The most important one being, dietary issues, smoking, alcohol consumption, and sedentarity. So that's also a very important element, because these are things on which we can have actions on, we can have influence on, and that's one of the elements. So if we go also once again a bit further into the details, what we see is that if we check first the context in the young, that's rather going better than it used to be, in the sense that smoking among adolescents has decreased. Similarly, an healthy alcohol consumption and excessive alcohol consumption has also tend to decrease over time. But this also, same thing, we have also to dig a bit further. There are some countries that are extremely well performing, and others for which we see less good results. And it's not in that case, in the risky behavior among young, there is less of this divide between West and East of Europe, because as you can see, for instance, the highest level of binge drinking behavior among adolescents is in Denmark, which I've lived in Denmark for years, so it's something I've seen firsthand, but that's something that you would not have expected, like empirically as a first thought. So if we move on to adults, also similarly, alcohol consumption is is a very, very important issue, a public health problem. What we know is that roughly today, on average, Europeans consume 10 liters of alcohol per capita, which is quite high. Same thing, we have also important nuances and variations across countries, with here a more clear gradient west-east, but Same thing, we also have to analyze in a country like France, which has at 11 liters per year roughly, you have also an important difference across regions and so on. So things also have to be checked and looked a bit more in details to have a better picture of things. And similarly, you have also binge drinking, so excessive alcohol consumption over a short period remains an important issue, more particularly among men in Europe, as you can see on the small graph on the right. Here, so another big issue, as you know, and that has not been progressing very well in recent years, is the problem of obesity and overweight. So we are not at the level, and hopefully we'll never reach the levels of that are across the ocean, but that we see in the US. But still, what we see is that first, the level of obesity and the obesity rates and overweight and obesity rates have increased in almost all countries in Europe, be it among adolescents or adults. So same thing, it's a growing issue, and that's something that our societies will have to deal more with all the implication it has in terms of metabolic diseases and cardiovascular issues. So that's also something that is growing up, is already present, because we have roughly 15% of the European population today that is obese and I mean measured and considered as obese, and this has increased over time. And also we see that the upcoming problem, because all the young that are today being overweight and obese will become adults in the years to come, and that will also add up to this current situation. So a very quite worrisome also issue here, with also similarly variation across countries. It's a much more bigger problem right now in Southern Europe than it is in Northern Europe, but same thing, the trends are here for Northern countries, and the situation will worsen in recent time. So now I hand over to Joseph, who will tell you about what can a health system do facing these challenges.
Thanks very much. Yes, what can the health systems do? I mean, a good part of this, first of all, it's indeed a pleasure. And Martin, the collaboration with you, Martin Seikel, the Commission, the OECD Observatory taught us lots of things. Among others, to be sharp and short, communicate well. And a lot of what I like to do now is just show some figures, but hopefully to trigger for you to actually look at the profiles and particularly at the companion report. A lot of the emphasis was, how do you summarize the complexity in 15 pages, which you need to blame Martin and his colleagues? It's some of the biggest pain we have had, right, at the OECD and the Observatory, because, we're specialized in writing long reports and deep analysis, but they were very extremely tough with us, no more than 15 pages. It has to be said, though, that when we asked them for comments on our template of 5 pages, we got around 50 pages comments, so of things we needed to add. But then both the Commission, the OECD, and the Observatory were very, very rigorous and managed 15 pages. And that's painful, because there's so much nuance that you want to put in there. But I think, and that's where, as Martin said earlier, I'm very, very keen, we're very, very keen for you to shout back at us and say, you missed that, you missed the other, this is very important, even within these 15 pages. So we went in the 15 pages is give you a flavor of what's going on, and particularly, I like to highlight what Martin was saying, get voluntary changes. Get member states thinking, what does it mean for me? And these figures that Guillaume was showing and the ones I'm going to show you trigger a lot. I don't know what they mean in some instances. Some instances mean lots of things and nothing, but certainly they make you think. They realize that there is a problem somewhere, somehow, that you need to look at. So it's been very useful in terms of communication. And later on we'll have a debate, and I should move quickly, Caroline, I know. We need to talk about issues of transformation and change. And this is exactly what the Commission, if I may, and echoing what you said, Martin, wanted with this exercise. Put evidence that triggers change, that makes member states think about what they need to change, how they need to change, and look around the region. Is this famous natural experiment we have in Europe. And the key role of the Commission, with the support of some of us, is actually to use that evidence to trigger, to produce change, hopefully in the right directions. So we have 3 aspects. Again, I can show you, if you're my psychiatrist, I would tell you the pain on saying why effectiveness, access, and resilience. Why these three dimensions? So we went backwards and forwards with many of these dimensions, and we thought we ended up agreeing with the Commission's main policy that these are the best dimensions to try to communicate, to explain what happens with the impact of health systems in the region. So how do the health systems address these challenges that Guillaume has put on the table? And as I said, I will be brief. I know you should never trust a speaker when they say going to be brief, because they never ends up being brief. And uses a lot of time talking about wanting to be brief, right? Okay. This is a controversial one as well, but a lot of fun, very interesting. This is avoidable mortality, either because of treatable or preventable. And then there's lots of debates about how we got that to that. I mean, the ECD, the matrix, our dear Chris Moore's matrix, the Eurostat, of course, about whether we are measuring those okay. My colleague Guillaume knows an awful lot about that. So we can debate that if you want. But we can say, I love the figures around 1 million because people remember those. We didn't make it up though. More than 1.1 million premature deaths in the EU could be avoided through better prevention and healthcare. So if the health systems were more effective, if we were better in prevention, we could be saving these amounts of lives. That's the number. That's a number that is very attractive. Maybe it's 1.5 million, maybe it's 2, maybe it's half. But there's a large amount of cases that we could do far, far better. And that's what matters. Second, the variations are enormous. Where the other day, actually, the first presentation in Parliament of Commissioner Kyriakides, I had the opportunity to be in the same platform with her. She was excellent bringing up the issue of cancer, so many others, and showing, we were there with the U40, the parliamentarians under 40, which I think is ageism, by the way. Some of us were above 40. So, no, this is a joke. But we're talking about the differences between, this data is on cancer and the differences in survival between different parts of the region. The differences are enormous and shows not only resources, by the way, it shows effectiveness of prevention, it shows effectiveness of primary care in detecting, it shows good coordination between the levels of care, and it shows good treatment. But it's not just about pharmaceuticals alone. Let's remind ourselves about that. Martin has very nicely put this issue on the table, so I will not talk about vaccines. One other aspect of effectiveness, again, lots of debate about this measure, but I think it's telling us a very interesting story about primary care. This is avoidable hospitalization in the face of effective primary care. So for a number of diseases, what we call tracer indicators, asthma and COPD, congestive heart failure and diabetes, you would expect very low, but very low hospital admissions if primary care would work well, it would be effective. Many of them would not be decompensated and would not need to be treated in hospital. So again, a cool number here, which I need to find. Over 3.5 million people in the EU were admitted to hospital for these 4 conditions that couldn't be treated in primary care. And it tells you a story about Portugal, Italy, Spain, Netherlands, Iceland, some of those perhaps being more effective. Of course, there are many issues there. You could say because there's not access to hospitals, because there are waiting lists. There are lots of debates there. But it tells you there's something you need to look at, and definitely tells you about the effectiveness of primary health care. Accessibility. Again, in this flash, I mean, the whole point here is for you to take some of the profiles that are outside, take them home, read them and start using them, and call upon us, meaning our group, we have large teams, to work with you, with your organization, with member states, to try to support with that evidence, looking at a particular issue on your own countries or in your own organizations. This is access, really summarizing the whole issue of access in 2 important figures. But it gives you the 2 dimensions of access. It's beautiful, of access, not access. This one is about perceived unmet need due to distance, due to the money barrier because of out-of-pocket, or due to waiting lists, lack of supply. It shows the differences in that perception. Of course, careful about perception, expectations, and so on. That's an area we can discuss later if you wish. and you see the large differences in the percentages of population. It's around more than 10% of low-income people in some EU countries report unmet care needs. It's an important element. Actually, a good part of this exercise, as Martin Sekel already highlighted, is been to do more work on access and to look what are these barriers to access and how can we address those. And we can talk about the policies in a minute or later on in the debate. But clearly, it's not only about differences in average access, but also differences in low and high income groups in terms of accessing services. The one that now has been developed, and it's a very useful one, is the catastrophic spending. Don't know how familiar you are with that one. It's the concept of financial protection. It's not only that a money barrier may not access health services, not allow you to access health services, but if you decide to pay out of pocket, you can end up going into catastrophic expenditure, using your available income at home to actually buy for services and denying other kinds of goods you can buy with this income, like food or many others. So it's a high percentage of disposable income, I'm finishing, used on that area. And of course, there's a clear correlation with out-of-pocket payment. I don't have to remind you here that out-of-pocket payment is an issue that we need indeed to address and is still very high in member states. The last two figures, again, are a bit convoluted perhaps. No, not convoluted actually. We managed to summarize an awful lot of evidence in these basic figures. So let me just spend 1 minute on this one. Treatable mortality. Remember I was talking about treatable mortality? So mortality that should not happen in the presence of effective healthcare services. It's in the vertical axis. So you have Romania, Latvia with high levels of treatable mortality. And here, expenditure. This is a very summarized indicator about efficiency. So we are now in resilience, the ability to respond to challenges, to challenges such as the crisis, aging, challenges in the reform of the health system. So that's one of the indicators of resilience as inefficiency. So given the amount you have, how much treatable mortality you try to get, there is a clear correlation between resources and treatable mortality. However, and this tells you an awful lot of stuff, these countries with the same low level of treatable mortality spend huge differences in expenditure. Is that difference in efficiency? Probably we are not measuring very well the risk factors. But it says you as well that at certain levels of expenditure down here is extremely difficult to do anything really. So we need some critical mass of expenditure as well. We should not underestimate that. That one, I promise, Caroline, I'm really sorry, but I'm still within the 6 minutes. So this is a very interesting, my 6 minutes, I'm within my 6 minutes, so I should not pay. Sorry about that. Okay, I'm practically there. I surrender any questions. I'll have those later. But these are really important. There's so much you can do with one of these figures. It took so long, our colleagues in the OECD, ourselves with the Commission, to try to summarize very complex issues in one figure. This one is beautiful. Look, nurses and doctors. Look at the huge differences. What does it tell you? Well, the guys in this quadrant, they have real problems about they're losing doctors, so there's all issue on nurses, there's issue on retention, there's issues with code of practice and ethics between member states, by the way. So there's lots of issues about retention, it's about migration and so on. But also here tells you that there's a lot of unclarity about the best mix to provide services. Even if we're so unclear between doctors and nurses, imagine when you go through the other levels. And Martin Sekel has put already one of the trends, the skill mix, as one of the areas that we need to be working much more in depth. It's a shame, but I have to finish. The lessons are quite straightforward. Perhaps to highlight around the resilience, I already talked about, the efficient use of resources, skill mix planning, good governance is fundamental. Start with the bottom, as you can see. Access, and particularly vulnerable groups. We do pretty well in this region in terms of access in comparison. I think it's those vulnerable groups that fall out of the system in moments of crisis where we have to direct our best efforts. Most of the population has good coverage and access, but it's these vulnerable groups that cause some of the problems during crisis, financial crisis or others. I'll leave it here actually because I think I already exhausted my time. Thank you very much.
Thanks a lot, Josep and Guillaume, for this analysis. And I must congratulate you also that you managed to cover so much still in a few minutes and slides and pages. But still, it is quite a lot. It's effectiveness, it's efficiencies, resilience, it's access, it's literally everything. So I was wondering, looking at the future also and aging, and what are the elements that you would advise member states to really focus on? Is there, can you somehow prioritize in all of the findings that you presented? From my perspective, it would be on prevention. We know that about 3% of national healthcare budgets go to prevention and promotion, so that would be my recommendation, but I haven't done the detailed analysis as you did. So I was wondering, could you elaborate on that? Guillaume?
Okay, thanks for that question. It's not an easy one, I must say, but the thing is that we have to clarify the terms we're talking about. What do we mean by prevention? Are we talking about prevention among people that are already in the health system, or before? Before that, people just like the general population, and about behavioral interventions, like it's more the right term to focus on here. The thing I have in mind here is that we're expecting a lot from prevention. There's been a lot of attention put and a lot of debates around what can prevention bring, and with the idea that prevention would help to save costs. I don't think that's that straightforward, in the sense that you have preventive interventions that are cost-saving, but you have others that are just cost-effective, and you have some preventive interventions that are not cost-effective at all. So the real question is, why are we expecting more from prevention than we expect from any other health intervention? Like we are not putting the same pressure on, when we assess treatments, medications, in terms of cost saving. We're already happy when it's slightly cost effective, and we even cope in some therapeutic areas that we will focus on soon with the European Commission on cancer care, for instance. We're even happy with medicines that are really not cost effective at all, that really cost a lot. They're not very little value for the money they bring, and we still pay for them, and we still buy them. And when it comes to prevention, we tend to sometimes have a vision that we say, well, if we have to spend for prevention, that's not worthwhile. So that's a bit a weird discussion, and the main issue I see here is that we're driven by short-termism, in the sense that we say that, okay, what I want is to get some return right now. And when I invest on a medicine, at least I see that I'm treating. I can have numbers. I can have figures. I'm treating X number of patients. I'm gaining X years of life, maybe, hopefully in good health. When it comes to prevention, it's much more fuzzy. We have to invest in the medium long term. So the real question I'm having is that, I think that prevention, and mainly behavioral interventions, which are much beyond what health system can provide, and I think in that sense, investing more in education and also brings as much to health than what health system can bring is the real option and way forward. But that's more behavioral rather than the preventive action. And the last thing I would like to mention here is when we refer to prevention, we tend to. I'm sorry, it slipped out of my mind immediately. It's just like, but
It's very clear, the point that you made. Yes, yeah. And I would like to add that from WHO data, it has been calculated that about 10% of health inequalities can be referred to health systems. So health systems can cover about 10% of the reduction of health inequalities, while other factors like living and working conditions and so on, social protection, that make up of the other percentage. Joseph?
I mean, it's the usual suspects, Caroline, and then let me just give me 30 seconds. It's the usual suspects. I mean, we've seen, in addition to prevention, of course, I mean, the SDGs is historic opportunity now, and you see that how the Commission and our new President has been very, very good at bringing the SDGs on the table. I think this is a historic opportunity, and it sounds grand, but it is grand, actually, to make a difference because of what you just said. Within the health system is the usual suspects. It's effective primary care, makes a huge difference. I mean, if I had with a few minutes, we can go and analyze some countries around that. The other usual suspect is, of course, integrated care. We still have an issue with financial protection and vulnerable groups, and there are substantial inequities, not as much as other regions in the world, but there's far more we can do there, and this is escaping even the Nordic countries that are particularly obsessive and trying very hard on inequalities. But you know what it all boils down? It's so boring and sad. It all boils down political will transformation processes, communication, communication, and communication. And ownership. So if I now go through and think through with my colleagues no more than I do, what worked well, even in health promotion, has been always linked to particular individuals with a huge political will, prepared to go there, transform the system. Of course, at certain levels of non-sustainability, of lack of resources, but that's what's made the difference. You know, how do you look outside the region? Take Turkey with all its problems, or Mexico when they managed universal coverage. What it was, individuals with names and surnames that manage. Actually, the former president of the Commission, now he's not president anymore. We can say, used to say something, which it always sticks in my mind. He used to say, politicians will know what to do. What we don't know is how to get re-elected after we've done it. So it is this element which explains a lot of that success. Of course, there are issues of governance, transparency. So a lot of the work, and I'll conclude here, is on sharing, and this is again another area we learned from our colleagues in Santé and DG Research, which are finally, I think, putting funding to transformation implementation, is how do we exchange good practice in transformation and change. And this new division that works very closely now with Santé, SRSS, the support division, is trying to do with Santé very closely how you support change in member states. With that information, with those skills, with those bottlenecks.
Yes. Thanks for that. So let's now move on to the next panelist and the European Court of Auditors, because only recently in December you've published an audit report on public health policies and public health work by the Commission and member states. So I would like to introduce to you Joanna Cocotte, and she's an auditor at the European Court of Auditors. The floor is yours, and you can take the microphone.
Thank you. Good morning, everyone. My name is Joanna Cocotte, and I'm very grateful for being invited to your event today to talk about the role of audit institutions at national level, but also at the European level. I work as an auditor in the European Court of Auditors, and yes, indeed, recently we've published a number of reports in public health. One document I would like to talk to you about is an audit compendium in public health. Is a document, a report that synthesizes 23 audit reports published by national supreme audit institutions. It also mentions our own reports on cross-border healthcare access. And we, over the last 2 years, we produced special reports on air quality in the European Union, on antimicrobial resistance very recently as a serious threat to health. And also in 2016, we had an audit on the EU framework for dealing with serious cross-border threats to health. The compendium, as I mentioned, synthesizes the work of national audit institutions. We have 23 national audit institutions contributed. This document has only recently been published. That was December 2019. So it is publicly available, but is being translated to all EU languages at the moment and will be then officially disseminated to all our stakeholders. And this compendium has been grouped, the audit have been grouped in 5 thematic areas in public health. First one is prevention and protection. Then the second one was access to healthcare, including cross-border access to healthcare, the quality of healthcare systems. And then the fourth one was about new technologies and e-health, so digitalisation in health. And then finally, the 5th thematic area was on fiscal sustainability and of public health services. So what stands out as a main message from our work and the work of national audit, supreme audit institutions, is that the situation in the EU varies significantly among member states, very significantly in these thematic areas. So, for example, if we take digitalisation in health, the situation varies among member states. If we take access to healthcare, timely access to healthcare, for example, or access to cross-border healthcare, it also varies in the member states. And for example, this fact that digitalisation in healthcare varied so significantly among member states was also the reason, like let's say a risk that we identified and selected this topic at EU level to be audited in our recent performance audit report on cross-border healthcare access. So we said digitalisation facilitates access to healthcare, especially in cross-border dimension. And we looked at performance of EU initiatives in digitalisation. And we focused on cross-border exchanges of healthcare data, electronic prescriptions, and electronic patient summaries. And we also looked at recent important developments in the field of rare diseases. And here we can merge the field of rare diseases together with the thematic area of digitalisation, because we looked at a very important innovation, the European reference networks. These are networks of centers of expertise for groups of rare diseases. There are 24 such networks in the European Union, established at the European Union today. And it is a digital initiative or innovation in a sense, because these networks, they operate via an online platform in which cases of patients with rare or complex diseases can be consulted by experts from different centers of expertise in the European Union countries. So we praise these initiatives. Of course, we also spot some weaknesses in the management of these initiatives, and we issue recommendations. Coming back to the compendium, I mentioned the 5 thematic areas. We also can, in this document, in this compendium, you will see, of course, country by country topics and weaknesses identified, but we try to group them per thematic area. So for prevention and protection, what was noted by this audit was that many campaigns and interventions were not sufficiently tailored to disadvantaged population groups. As regards access to health services, many audits note very long waiting lists for some treatment. Then as regards new technologies and e-health, so there were 3 national audit reports in Estonia, Bulgaria, and Latvia, and then plus our own on cross-border exchanges of healthcare data. What was noted is, especially in the member states, these 3 member states, that although e-health was very high on health agendas in these countries, there were significant delays in implementation of the e-health projects. And then as regards fiscal sustainability, we identified weaknesses as regards procurements or internal controls. I would like to encourage you to sign up to our website, and by choosing a domain, public health or environmental health, you will be updated on our products and our reports in this field. So this is what I would like to. I'm happy to answer all your questions and hear your reflections about our work.
Thanks a lot, Joanna, and I will open the floor for questions, comments later after all the panelists have spoken. So I would like to thank you for that. I actually had a look at the compendium report. I'm quite impressed because what I liked of it, that it really looked at measures taken, policies implemented in member states on public health. And then you give your analysis of that. And I was wondering, how is that going to be taken further by the Commission or by member states? I mean, also from the previous audits you mentioned on air quality and AMR, what are the lessons learned of the uptake of it, and what can we expect from this public health audit?
Well, when we draft our special reports that report on results of our audit work in a given domain, we list our observations, but we also issue recommendations. And for example, when it comes to our recent audit on cross-border healthcare access, all recommendations issued by the European Court of Auditors were accepted by the European Commission, and they are being currently implemented. So this is what's happening after our audit reports. When it comes to the compendium, I think what stands out from this report is how important public health is for audit institutions, for ensuring better management of healthcare systems at the country's level, but also at the EU level. That's more us. And I think this compendium might work as a peer-to-peer exercise, because we can see what were the main focus areas, what were the audit approaches, was it more financial audits, more compliance audits, or more performance audits. Definitely when we come and audit EU initiatives, we want to look at efficiency of instruments chosen and used to implement EU policies.
Yes, thank you. All right, let's now move on to our final panelist, Kasia Chabanowska. She's Associate Professor at the International Health Department of the University of Maastricht. Kasia, we've heard many recommendations and what it means for health systems, but now what does it mean for the health workforce, but in particular the public health workforce? I mean, is there sufficient leadership? What about the capacities in order to tackle all of these challenges? Kasia.
Thank you, Caroline. I'm really glad that I can speak to this audience, and I hope that my conclusions or my comments will resonate with things that have been mentioned by the panelists. And one of the reoccurring themes that we all could have noticed was a gap, which was often accentuated. Yes, that we are still dealing with a divide, and that we need transformation. And I would like to quote Professor Michael Marmot, who said that this is our moral imperative to act on social determinants of health, which actually contribute to this divide. But not only, I still would like to quote one more person, Richard Horton, who said that public health leaders nowadays, those who sit in parliaments, are actually divorced from public health benefit. And it is the time now to act, to have courage and act. So the problems, the areas that have been highlighted by the reports actually really deal with public health issues, and public health as the science and art of promoting health and preventing ill health through organized efforts of society, yes, would never happen if it is not for workforce, for people who stand behind it. And who are those public health workforce? So we can talk of those who deliver directly public health services, yes, in their work and the core public health workforce, and those that have some of the activities in their daily work, yes, devoted to the delivery of essential public health services, and this is wider public health workforce. And who these people are and what kind of capacities they need. If you read the literature, these are the people who, apart from public health knowledge and skills, they need to have political savvy and they need to have leadership qualities. There is a very interesting publication on the talents of public health leadership, or what kind of skills they need to have, and this is systems thinking, policy analysis, entrepreneurial orientation, and of course transformational ethics and leadership. So this is what you can find. But on the other hand, when you want to find out how much money is spent on the development and support of public health workforce, you will not find any indicators. So the closest would be this 3% that is spent on prevention that can also explain whether they are supported. But they are not supported. There are a lot of studies that talk about health workforce development and planning. But specifically about public health workforce development and planning, we can't find anything. And we don't know how many of those we train. What is the enumeration? Are there databases where we can really know who they are and how they can be used? So what about the leadership? Yes, now what is public health leadership? So as you can see from the discussions, we need a radically different type of leadership that is involving many actors and many sectors, that is horizontal, that is collective, and that is democratic. So we are not looking at individual figures unless these figures are able to initiate collective actions and bring different stakeholders who contribute to benefit, public health benefits of the populations. And actually, we can say that a public health leader is someone who actually is unknown. But when his or her goal is achieved, then the people can say, we have done it. So the leadership is to bringing people together with the individual end user in focus, translating the knowledge into the language of those end users, with the patient or individual in the center. And in order to achieve this type of leadership, we also need to rethink science, bring science closer to the society. And as Joseph said, communicate, communicate. Yes, but these are different communication means. Yes, how to talk to younger generation, the so-called Gen Z, who are digital natives. Do we use the same operational system as they use? Sometimes we fail because we still are in old Windows talking to those people, right? So this is the new type of leadership, and I think it works very well if you look at different achievements of public health. Convention on tobacco or some other things, and even the collective work that you have presented today. And now going to leaders, public health leaders. That was leadership, and now individuals. Yes, what do they do and what do they need? I would like to share with you one of the works that we have been doing together with the Coalition of Partners. We have developed a special competency framework for public health workforce. The competency framework that shows we can't work in silos, but and not in disciplines, because we have to work across disciplines to deal with this cloud of skepticism that does not allow for vaccinations, for instance, or the separation that we experience, also a divide from inner meaning of people with the results that now are produced that nobody wants, like environmental waste, for instance. Yes, so how do we deal with that? Bringing the competences in the interdisciplinary, interprofessional way. So the framework that I mentioned has something like science and practice, meaning these are public health areas like methods, epidemiology, statistics, and also public health law, policy and ethics, and One Health and security. Then we have communication and collaboration, where we have public health leadership, culture, advocacy, the areas that are extremely important, and system thinking. And then we have something like performance and delivery, which is management, governance, reflective, ethical practice. So this framework is highly recommendable to help public health professionals work together. And then who they are. yes, who these people are. So these are the people who are networkers, connectors. There are specific talents that they show. Those who can shape and organize the reality, who know and can interpret. And these are those who can strategize and deliver public health interventions, and who can initiate broad interdisciplinary and intersectoral networks, and finally those who deliver the interventions for public health benefit. But we need to support them. We need to know how many, who they are, how they can work together to bring public health benefit. Thank you.
Thanks, Kasia. I wanted to, why not? One of the recommendations highlighted also by Martin and Joseph and Guillaume is this skill mix and task shifting, and what does this mean for the public health workforce. And also if you think of the other workforce that contribute to health, like teachers or police or, they have a role to play too. So what is your perspective on this?
Thank you very much for this question. I think it's very relevant, and recently we have been working with our colleague Stefan van der Broeke on a chapter for European Observatory on skill mixing in health promotion, and we have done a systematic review on this topic, and it turns out that really pharmacists or school nurses can do a lot of different tasks and change, and which is very cost effective and cost efficient. But I was thinking a little bit further into the public health professionals and how they can mix skills. One of the areas that is very important when we look at vaccinations, when we look at the social determinants of health and digitalisation, is public health law. And actually, when we think about public health professionals or people who work in the field, we talk to the lawyers. And the knowledge of public health law among public health professionals leaves a lot to be desired. But this is one of the areas that we also need to study. And there are 5 public health law services, yes, that is a framework, which actually should be taught early in the curricula for public health professionals, which deal, for instance, with the surveillance of public health policies. And when we talk about vaccination, yes, when we talk about road safety, when we talk about digitalisation, obesogenic foods, then public health professionals can do that instead of instead of lawyers. That is very expensive. Then we can also do the advocacy, yes, and the research on these policies. So I think that when you look at this competency framework, I mentioned that public health law is one of the areas. So going back to you, education, yes, and investing in continuous professional development of public health professionals that currently doesn't exist would be the way to go.
Yes, thank you. Very important point.
I tried to move it in a different direction from nurses and pharmacists doing health promotion, but also some other
lawyers. Yes, very important. Thanks to you. Now I would like to ask Martin to reflect a little bit on all of the comments and the contributions by the panelists. And I was also wondering, I have a specific question for you, is to what extent you feel that in this new period, like that the semester as primarily an economic and fiscal tool, is now going to become a more important tool to take further health policy also with member states. As you know, that van der Leyen has very much societal well-being is very much also important to her in addition to prosperity and economic well-being. And the semester is supposed to also embrace the SDGs, so there are opportunities. So I would like to hear your reflection on that too and on what the other panelists have mentioned.
Yes, thank you. I think actually this is the heart of the question. First of all, I think this semester has proven to be an invaluable tool. I know initially in the first years, especially when we were in the, let's say, depth of the financial crisis and the most critical phase where the emphasis had to be on survival and basically keeping countries afloat. But we've learned a lot through these past years. And I think if you look at what the semester is producing now, there's actually a much more also strategic vision, also trying to understand the drivers of the problems, not just to react to issues like unsustainable expenditure, but also to examine, for example, the roots of that expenditure. If you look at, I don't know, pharmaceutical spending, or if you look at issues of workforce. And you will see, I think quite clearly that even in the past years, there's been increasing emphasis on things like prevention, like health promotion, like primary care, integration of care. So this has been a very important, but why? Because it links a bit to what we were discussing earlier. It would be the biggest mistake to think that improving public health is just the responsibility of health ministers or health ministries. In the past, this was sometimes the perception because, you know, in the good old days, in inverted commas, health budgets were very well protected, they were ring-fenced, and nobody was really thinking about what was under the hood of the engine and basically looking at the mechanism. So the engine was there, it was always working, it was always well supplied with fuel, and we never bothered about it. And now we have been taking the trouble to actually look at this engine and see whether actually parts of it need to be updated, and there are lots of upgrading which needs to happen. So it's been a good exercise because you need, first of all, the Minister of Health to do his or her job properly needs to have the full support of the rest of government. You cannot have, you know, the finance minister or the economics minister or social affairs ministers, you know, standing apart from this. That's the first lesson. Secondly, from the Commission's perspective, yes, we have a Directorate General for Health, and as you all know, there's a very ambitious agenda placed in front of the Commissioner for Health, perhaps the most ambitious agenda any health commissioner has ever been tasked with. But health needs to be even broader than that. There is a strong emphasis now on the SDGs. This is really important because, again, here there's been a big shift. You know, in the past, we always tended to kind of think that sustainable development was something happening elsewhere in the world. And now we realize, for example, the issues of the inequalities between and within member states. This requires a lot also of work to achieve those SDGs also within Europe. We are well placed. I think if you look at many of the indicators for health, I mean, Europe probably is one of the best placed regions to achieve the goals by 2030, but we're not there yet. And in some areas, I think we have to be very careful. The biggest challenges are the inequalities. The inequalities have a strong also political, you know, price tag. If we do not address those, these are the centrifugal forces that are tearing Europe apart. I mentioned, you know, there are socioeconomic differences, there are vulnerable groups, even differences between people who live in urban areas and people who live in rural areas. The access to healthcare, living in a rural area, even in some countries that are otherwise would be classified as rich, you know, high GDP and so on, you will see even within those countries, makes a big difference if you live in the capital city or one of the main cities, or if you live in a rural area. And this is something which, if left untackled, will create enormous political implications. So obviously this has to be a priority for the Commission. It will be a priority for the Commission. We also need to find better ways of using our funding instruments. We have very powerful instruments we can deploy in Europe. Various types of funds. I mean, we have already some very good examples. Like, for example, we have been using the structural reform support to work with countries, for example, who don't yet have a good cancer screening system, to actually help them, because in putting such a system in place, they not only improve public health, but they also save money in the long term. So this is also a very important example, and we will be looking across the board to all the programs that we have to find the best possible match between issue and instrument. This is, I think, a key responsibility for the Commission. If we can use all the tools in the toolbox and not just one or two. And I think the final challenge I would mention is that we need to move away from this thinking that, you know, we say it's either the member state's responsibility or it's Europe's responsibility. It's our collective responsibility. Subsidiarity does not mean we pass the buck to each other. It means we have different roles, but we work together on the same issues. And this is why this analysis of the state of health is so important. Of course, the responsibility for delivering health systems is with the member states, but the member states should feel supported, particularly those that are in the weakest position. They should be able to rely on the European Commission and other European institutions, and indeed on support from other member states in terms of transferring of best practices and so on. There's a lot of work which can be done there. And so I hope, and I am confident that the next 5 years, particularly because of the themes chosen as priorities in the area of health, will help us achieve that transformation.
Thank you, Martin. So I would now like to open up the floor to you for your questions and comments. And I would like to take a few questions and comments first round, and then I'll address it to the panelists. So who would like to start? We have heard many things, but we also heard some things not, like migration and health, aging, environment and health, mental health. Yes, please. Oh, there's the microphone.
My name is Michal Boni, former member of European Parliament, now related to APCO and Martin Center. Thank you very much for the conference and for those reports. Two small questions. Firstly, the assessment of European reference networks. It is not clear for me if we have money for the future. And it is important because the role, the significance of this network is clear, and it is changing mind in many countries, because we, on the other hand, need to remember that healthcare systems are under the member states' competences. It's not so easy to create some kind of harmonized solutions. And the question to Professor Czabanowska, could you explain much more precisely the new model of leadership, yes? Leadership at the European level, and how to join the leadership at the European level with those levels at the national level, because it's crucial from political point of view how to integrate policies and activities at the healthcare area.
Yes, thank you. Any further questions or comments? Yes, Zsolt?
Since Caroline, you also mentioned migration, I wonder if we have data or statistics on the health situation of migrants in the EU. I mean, we hear a lot about that some of these people live in very poor conditions, and I wonder if also what kind of access they have, what kind of insurance they have, if there's any information. That would be very interesting, I think.
Mm-hmm. Thank you. One more over there.
Hi, my name is Michael Strubin, Digital Health Director at MedTech Europe. I'm going to be speaking a little bit later in more detail. I was struck by one of the slides that grouped some of the low spenders on healthcare and directly correlated them with low healthcare outcomes. And one of the countries that we looked at and that I have a special interest in is Estonia, because it may actually be spending very little money on healthcare, but it's one of the superstar achievers in digital health. And so I was wondering, and maybe invite you all to reflect on this, is to what extent does digital health may have a lag in terms of health outcomes? Or is it just something that we put on top, a kind of a cream on lipstick on a pig, some would say? Or do we expect digital health to have a more long-term effect on healthcare outcomes? Maybe just, that's it.
Thank you. Yes, interesting question. When I studied these graphs, I saw that Estonia was also the country with the biggest increase in healthy life expectancy. So I was already wondering, how did that happen? All right, so a set of questions. Who would like to start? Would you like to take up the leadership question first?
Thank you very much, Michael, for the question that you have answered. What does it mean, leadership, that we know from the European perspective with these horizontal partnerships, citizens' involvement for a specific local situation? Yes, and how we can translate that. Do I understand right your question? Yes, so what is important to know is the context, where we are, yes, in what situation. And then what is the vision and strategy and the objective? Yes, what do you want to achieve? It has to be very clearly formulated. And then what happens? We assemble, we try to bring together a big coalition of stakeholders, yes, from different levels to convince them to our problem. Yes, and you can't work alone in isolation, and everybody must feel that they equally contribute to the problem and that they actually own your problem. The moment when you get this, that someone feels I'm the owner of the problem, they will be with you. And then the specific work will follow with finding out why we need this, what we can do, and then how we can do. And there are specific tools that can go. But I would say this is the way to start. Context, specific vision, objective, then bringing together everybody to the table. And that's it. Thank you. Does it answer your question? So I gave you a recipe.
Maybe on the...
Yes, on the ERNs, I brought the concept of ERNs to the discussion, so I can answer your question, maybe together with Director Sekel. Indeed, the fact that the European reference networks face significant challenges to ensure they are financially sustainable and able to operate effectively was one of our main observations in the recent performance audit report on cross-border healthcare access. And one of our recommendations was to set out ways forward to address these challenges so that they could operate in an effective way. I don't know if Mr. Sekel would like to.
Yes, indeed. This is a very important area where we are following up the recommendations. I would highlight there are two main challenges facing the ERNs. One of them is, of course, the financial sustainability, and there are two possible solutions to that. First, some member states are already linking the reimbursement or compensation to the centers to their membership, so they receive financial support from their member state for being members of an ERN. So this is a recognition of the fact that they are able to provide added value to the health system. And secondly, from the European side, we are looking at ways in which we can use, for example, the research program, because I think we all realize that the ERNs can be very valuable infrastructure for research. Just to point out two important facts on rare diseases. At the moment, it still takes 5 years on average for a rare disease to be diagnosed. That's an average, 5 years. And we have only treatments for 1 to 2% of the 6,000 rare diseases present. So there's a lot of ground for research. Of course, to do that, you can only have attractive environment for research if you have not just a network, but a well-functioning network. If you have access not just to a small part of the rare disease population, but through the networks to the entire rare disease population, including the majority who will never be directly referred to the ERNs, but who should be able to be, for example, enrolled in clinical trials, etc. Also because this is something they need. The second challenge we have is the need to fully integrate the ERNs in the national health systems. So the ERNs should not be the tool of last resort. So when we run out of options, we refer the patient to the ERN. Of course, in some cases, that is also useful. But it would be really important to ensure that each and every patient in Europe that could or is suffering from a rare disease has a pathway for diagnosis and where available treatment. Now, that pathway, of course, will be defined by the member state, but it should fully integrate the ERNs. So this is really important, so that through the ERNs we can have access to data and to the full population of patients. And this, I think, will greatly accelerate. I am confident that if we do this, we could, for example, our calculations are, we could reduce the time for diagnosis from 5 years to less than 1 year, which would be a dramatic improvement. But of course, this is only possible if there's a very good, but these are the two challenges, yes, we are working on.
Thanks. Joseph and Guillaume, can I let you to respond to the questions on migration and on the expenditure and health outcomes paradigm, and maybe also to clarify the situation in Estonia and the reference to digital?
I will rather pick the Estonia one, which I can say some things about, but much less on migrants, which by definition is a bit more difficult to assess and to measure in details. For Estonia, the thing is that, interestingly enough, Estonia, I would say we can see the figures of Estonia the way we want, in the sense that we can say, well, it's still very high. The mortality from treatable causes remain high, but we can also see and compare it, for instance, with the other Baltic states. If you check Latvia and Lithuania, I mean, these three countries come from exactly the same historical background. The population are roughly similar. They don't speak obviously the same languages, but I mean, culturally, they're very tight. And what we see is that we're much better in Estonia than in Latvia and Lithuania in terms of the overall performance of the health system and the health of the population. So it means, and this is reflected in the fact that Estonia is one of the best performing countries in terms of the progression of life expectancy over the last 15 years. I think it's the first one, actually, that has gained the highest number of years in the last 15 years. So we can also see what has been done so far, and that the progress, what has been made. So I mean, things don't happen overnight, obviously, and all these changes take time, and Estonia still grapples with important issues like lack of workforce capacity overall, some general issues also with the low level of investment on health and the very high level of out-of-pocket expenditure, which leads to catastrophic expenditure and pushing people into poverty. There is also the issue of marginalized population within Estonia. I mean, we're very rarely mentioning the question of the Russian speakers in Estonia, who are really, having troubles in accessing some services and so on. So there are still a lot of issues in Estonia, but I really think that the performance we see, can be related to serious transformation of the health system that have happened over the years, and thanks to the support also of partners like the Observatory, like WHO, who helped them and supported the authorities in the reforms that have been undertaken in last years, and that's for sure. I would say I would put it rather in a better performing country group rather than anything else, especially considering the starting point for Estonia. And I hand over maybe to Joseph to complement and talk about migrants.
Just to complement on Estonia, should be cautious, and I like you asked this question about trying to make these basic correlations. I was trying to be quite pragmatic and quite critical myself. Obviously, it's not about more money, more performance. There is some element of more money, more performance. But if you recall the figure, among those highest spenders, there were huge differences. The same performance was achieved with different levels of spending. What does that mean? We need to talk about that, but there are clearly space for more efficiencies. And the point about the lowest performance, it wasn't to say, because there are differences, substantial difference among those. The point there was to say at certain level of expenditures, forget it, it's just too little. Of course, you can do efficiencies everywhere, but there are levels like in Bulgaria and Romania with very little human resources and so on. Still a lot you can do, but it's very dire, and we need to support and lobby for more resources, full stop. But even within those, there are differences. To add Estonia, Estonia is not digital health, I'm sorry. Estonia is public health. It's public health, and they got their act together, as you say, with the support of WHO and others in the reform of the systems. But Estonia has an advantage, it's full of Estonians. So Estonians, like Finnish, they have a particular kind of character at the time of adopting digital health or doing reforms or discipline. And this is one of the issues that I would like to highlight today, and building on what Martin Seikel said earlier, is not the digital health, it's the ability to adopt, accept, understand, and implement digital health. Effectively, the Finns and the Estonians were ahead of the game together with the Swedes. basically are not worried about trust. They're not worried about the government. They just basically trust the government. They don't miss, it's not like Germany or the UK or even this country where there are huge issues with privacy, and perhaps the right ones. I don't want to get into that. We'll go into that the next session. I'm sure you'll raise those issues. But effectively, Estonia has progressed so much on digital health because it's part of the fundamental culture, first, to use digital health, and secondly, the enormous trust on the state, on the government, on having this data available. But remind you, it's health systems and particularly public health, it's HIV/AIDS and cardiovascular diseases. Second, may I say something about ERNs, even if it wasn't my question? I'm a real converted ERN person, Martin, as you know, and as you are, I know. This is the way forward. This is the roaming charges. The roaming charges have been one of the best things for Europe. ERN is the same thing. The ability to be seen in other countries, not literally but virtually, is fundamental in terms of communication. Secondly, the issue of sustainability, I totally agree obviously with all the comments of Martin, but it's a national level. In terms of the Commission with you, Martin, as you know, we're trying to do a study about the use of resources and the costings of these ERNs. When you talk to these ERNs, they get so many intangibles. Specialists working together, doing research together, developing guidelines together, exchanging training programs together. Some of our countries in Europe are very small and have huge benefits in terms of trying to work at rare disease. The actual resources used for teleconferences and so on, telemedicine, are very low. And if I may say that I don't know how I can say that, but we had a telephone conference with all the ERNs Monday with your colleagues at the leadership, Martin. And the issue is not money as such. They're very rich, these hospitals, have lots of benefits. In the West, in the East, it's a different thing. They're with few, but in the West, they really see the enormous benefits. And I like to go further. Subsidiarity or not, I don't think it has to do with subsidiarity. The potential of networks in Europe is huge because now everything is a rare disease. Everything is precision medicine. Everything is personalized medicine. We need to get this. This is one of the big advantages of Europe. We need to get these people training together, exchanging practices. Yes, Caroline, I stop here. But there's so much we need to look at the RNs as a model of working on networks across countries. Mm-hmm. It's a real winner.
Yes, very good. Working
Sorry,
better together.
I'll talk about later.
Yes. Now, I just wanted to give the audience one last opportunity to ask questions or to make comments before we break up for lunch. So I see two first. Yes, please. If you can also state your name.
Yeah, thank you very much. I'm Han Jianli from Mission of China to the European Union. And thank you very much to the panelists for your very good presentations, and to Deputy Director General Seychelles especially. And I have really taken a very important message from you, including both the health is not just the mandate of the health ministry, and also other important information. Also, as you rightly pointed out in your opening speech, non-communicable disease is actually not the only burden that we have faced, referring to the coronavirus in China. And this virus has caused so far over 400 cases in China, and also some cases in a few other countries. So far not yet in European Union, I think, but we are still very actively observing this. And China has taken very strict precaution measures, and also reactivated the joint mechanism of prevention and control. As Mr. Seychelles said, this health is not just the health ministry's mandate, as that mechanism is composed of 32 agencies in China. And so all the country is now working really hard on this. And also China has been very transparent in cooperating with the world and the other countries, and we notify, for example, the World Health Organization and the European Union as well, and some other countries every day on the case reporting, and also communicate with this, and including sharing the virus sequence with the World Health Organization, and so that other countries also can now diagnose very quickly the disease. So we still look forward to work very closely with the world, of course, including the European Union. And also, actually, just 6 or 7 hours ago, China had a press conference talking about this, the control of this disease, and all the transcript is online, but in Chinese. If anybody is interested, welcome to come to me during the break, and I would like to to give my translation service for any information you'd like to know from that press conference. Thank you very much.
Okay, thanks for updating us on the situation. It's a bit more reassuring. Thank you. Yes, please.
Thank you. I'm Stefania Boccia from Catholic University in Rome. I'm professor of public health. It's more a comment than a question because I was listening to the excellent presentation, especially those about avoidable and preventable mortality. But concerning avoidable and preventable disability, we know from the companion report that there is a huge difference across European member states in terms of length of life lived with certain disability before death. And we know that Sweden is the best performer around 8 years, like Italy, more than 20 years lived with some disability, and we still know that a lot of these years can be reduced with very good preventive efforts, and especially those tackling behavior, as Guillaume said. So I also think that sometimes public health professionals and policymakers should be more brave, because we know that in Sweden, we have only 10% of the population that smoke. And if I'm not wrong, in 2025, maybe there would be a completely ban of smoking in Sweden. So again, my question is, what is your view about this point? Because it's okay, I'm completely in agree with you that a Ministry of Public Health cannot work alone. They should work with the Ministry of Economics, Agriculture, Infrastructure, whatever. But sometimes we have answers to some difficult questions, and we should maybe be more brave to put them in place, but it's just consideration. So I want to see your view on that.
Mm-hmm. Okay, that's an important comment. Okay, last opportunity. 1, 2, yes, over there.
Thank you very much. My name is Maciej Radzinka, and I work for Mental Health Europe, and I'm also a vice chair of a committee in European Health Parliament. And my question is about the silos that we are constantly talking about in the EU bubble, in the health EU bubble, and that we shouldn't work in silos, that we should create more partnerships and join forces. But my question is about the future of working together for health and the role of the private sector in health, and actually what are the risks of involvement of the private sector in healthcare and in health and in public health, and how we can safeguard the public interest when it comes to this cooperation, that we should, that we leave the silos, we work together, but actually everyone has its own role, and how we safeguard that actually the benefits for the public are on the top and are realized. Yes. Thank you.
Thank you. Very important question on the role of the private sector and the commercial determinants of health. So I would like to give all of you one more opportunity to make your final statement, as well as responding to the comments and questions that were just put forward. Martin, would you like to start?
If I make 2 quick points. First of all, I'd like to thank the Chinese colleague also. We are very grateful for the very good communication on this crisis. But I'd like to make the point about communicable disease in general, because we've seen a very lot of impressive statistics. If there's one thing that could disrupt all this, is communicable disease. And as we have seen, things can come out very suddenly in a very unpredictable way. But there are threats like I mentioned vaccination earlier, skepticism. AMR, it's very underestimated. There have been recent studies which clearly indicate more people will die from antimicrobial resistance than from climate change. This is the reality. And I think we are simply not at the same level. I hear very few political leaders speaking about AMR. It's still doctors, scientists, etc. speaking about the problem. So we need really to take this to the political level. So this is really important because this really can have a big impact. And there are some big problems we have never gone away: tuberculosis, HIV/AIDS, these kind of diseases, even diseases like seasonal flu, still kills a lot of people. Also, I think it's really important to really find ways to embed all these considerations also in other policies. Very often, the most important gains in public health will not come from health policy. Things like housing, environment, things like social welfare sometimes can deliver improvements in public health. So the key question also when we talk about health expenditure is also to see that we can also use other areas of expenditure in the right way. And sometimes I know we have a tendency, because we are public health people, we think that the benefits can only come from expenditure in health. But very often, the biggest health benefits can come from looking at the contribution of other sectors. I'd like to emphasize this as a kind of take-home message as well, if I may. Thanks.
Thank you. Then perhaps start with Joseph, and then we go on to...
Well, actually, I felt that the three last contributions were a beautiful way to wrap us up today. The multilateralism of China, I love that, thank you. I think the point in Sweden is fundamental, and how a lot of our day-to-day work, our Monday morning work as well, is how do we empower these policymakers. And there are many issues there to put on the table. One that I'm particularly fascinated now, and in the context of the SDGs, I'm sure Caroline and I very much agree on that, is what we call the co-benefits. The Observatory has started some work on that, which is not what the others can do for you, but what you can do for the others. This is how health is fundamental on gender equity, how health is fundamental to improve education, how health can be very good for the environmental agenda. So it's co-benefits. It's not saying, if you boil the environment, it's good for health. No. How health, by diet, etc., and so on, can have an impact on the environment. I think if we manage to articulate these kinds of argumentations for our ministers of health, of public health, so they have a more weight in government, if we support them when they have real day-to-day needs, there's a lot of the transformation, the leadership, the knowledge brokering, I think we have a real chance. And I think we need to change a bit our genes, the way we operate in this room, all of us, on how we see them, particularly those in university. We need to see ourselves as supporting them with these nuggets of information, evidence, and support, and so on. So I think that's I think will be an important conclusion today. And I think the public-private mix is the second one. Actually, if I may say, one of the themes this year, maybe the theme this year, I don't know if I can say that, but I always say what I shouldn't say, in Gastein, maybe dancing with the elephants in the room. That's my push in the theme. And I hope Martin will be there. And it's the commercial determinants, it's the elephants in the room. And the elephants in the room, we need to dance with them. Not very closely, with some distance sometimes, and have a judicious mix of carrots and sticks. So some are prepared to... I remember a long time ago in youth, I was running a plenary, and I had all the major private determinants of health there. We had some of the multinationals, let's leave it like that. Even Pepsi Cola was there, how politically incorrect. So they were there, and they were saying, I thought it was very important actually to mix them with the public health profession, although it was very much criticized. They were saying, listen, we're prepared to self-regulate, but only if the Commission and WHO and others, and particularly I really like to support what the Commission is trying to do, because WHO doesn't have that regulation capacity, the stick is there, threatening us, then we'll do that. But the self-regulation alone will not go very far. So yes, you look at, let's stop, but universal coverage, even WHO, even the whole movement in low-income countries and middle-income countries, we won't get universal health coverage unless we play with the private sector and we bring them on board. We have to dance with them, but with caution.
Thank you. Joe? Yeah.
Just a very quick comment. I think that, indeed, we need to have better performing public health professionals better trained and so on. But I really believe, I will use a quotation from Max Weber, the founding father of sociology. One day he was asked, what is a sociologist? And he basically answered, a sociologist is someone who makes a living out of sociology. So I think that we all have a responsibility, and we can all be public health professionals also, as long as we make a contribution. And I consider that someone like an architect that designs a building where he swaps the parking slots of people, so that they have to walk a bit more before they come to office, that the elevator starts at the third floor, and so on. All these persons are, for me, the real public health also professionals, because they're making a real contribution to the health of the population and so on. So I think that it's important to have people to lead that, but also to be able to understand that the health in all policy is really the answer. Then what to do, how to manage the question from our colleague from Sweden. Also, I think that we have to understand, and there is some sort of a revolution that we have to make in our mindsets. I think it's the sense that as long as we will consider the health systems, and that the leaders of health systems will only focus on the fact that we have to balance incomes and expenses, we will have this issue of saying that what's worth investing on and so on. I think that if we consider that public health and prevention also is a necessary element, we can spend on it only if we consider that the role of a health system is not to be balanced, but is to provide health to the population. You see, so that's also some sort of to be more bold in our approaches in this, and be able to handle that switch in our mindset. That if we consider that delivering health and improving the health of the population is not cost-free, then we will be able also to invest more in these interventions, that not necessarily, if we go beyond cost effectiveness or cost saving in the reasoning on that. So we have to be more bold in our approaches on this. And the last, very, very last point is that the relation on public, private and so on, I think have to be also made more, have to be improved also in the way, in the influence of one over the other. And I will just use a very simple example of what happened in the country where I'm living, in France, because there has been a huge attempt by the public health community to have the authorities taking up the dry January concept, meaning that we have just to take 1 month with alcohol-free, behavior, and just to check on our consumption, our relationship to alcohol consumption, and so on. And the authorities, the Ministry of Health, was keen in supporting this officially, and the executive authorities say no. As a matter of fact, we will not, considering the size of this market sector in France, and so on. So I'm just saying that as long as we will not be able also to make health prevail on other interests, there will be a lot to be done still.
Mm-hmm. Thank you. Joanne?
Maybe just 2 sentences to wrap up. I would like to underline the importance of audit institutions in auditing fields that matter to EU citizens in public health, definitely is. And just draw your attention to the fact that sometimes we can have audits that would be categorized as environmental audits, like our recent audit on air quality, but indeed these are also audits in public health, while air pollution is a pressing threat to health, and I would like to draw your attention to this report as well. Mm-hmm. Thank you.
Thank you. I would like to join Joseph saying that these 3 last comments were really very crucial, because the problems that our Chinese colleague presented really can disrupt, and we can feel that we are prepared, but then it turns out that we are never prepared and things happen for the first time. And then that we have to have courage to work across sectors and include those that can participate. And concerning the private sector, we have a lot of positive examples, and the Convention on Tobacco, and here there is a great success, and colleagues were working with the industries which are very strong. But just to have my final comment, I would say that the work that has been done by the colleagues, by the European Commission Observatory and OECD is a fantastic tool for public health decision making, the evidence-based decision making, and it can also initiate a big call to support the development of public health workforce and planning.
Thanks, Kasia, for these comments, and thanks to all panelists for these comments. I think we've had a very rich session. We have covered a lot of topics, which was very well set out by the State of Health in the EU overview presentations. We will have new opportunities that are coming up, which we didn't manage to discuss here. We briefly touch upon the semester, but there's also the Green Deal that has been presented with lots of links to environmental health. There is the Social Europe roadmap presented. There's an action plan on the European Pillar of Social Rights. There will be a digital strategy coming up. So loads of opportunities for us to link up with and to ensure the health and well-being of all of European citizens. So we have work to do. That's, I think, what I want to say here. I would like to thank Josep, Guillaume, Martin, Joanna and Kasia for your fantastic contribution, and for the Bruegel Institute for hosting us here. And there is a coffee break time now, and back at 11:30. What is it? 11:30, yes. Thank you.